call this meeting to order. Are Doctors Montgomery and Peralta on the phone?
Yes. Kathy.
Okay, great.
Yeah, Lee is here too.
Okay, terrific. We can hear you great. Included in your packets are copies of the minutes from December 18th public meeting of the Commission. If there are no changes or corrections, I'll entertain a motion for approval. Second? Any discussion? All in favor?
Aye.
Any opposed?
Aye.
All right. Commissioners, you've received the written updates from our centers. Ben, I understand you have a brief update on enrollments in the Health Benefit Exchange and the launch of the small group exchange.
Thank you, Mr. Chairman. As most of you know, the Executive Director of the Mhcc is also on the Maryland Health Benefit Exchange. The information that I'm providing is largely public, but I think given the challenges of the exchange last year, it's good to know that this year the exchange is launched without without any significant problems. As of Friday of last week, approximately 90,000 individuals had enrolled through the exchange in qualified health plans, and an additional 80,000 newly enrolled Medicaid enrollees had joined that program. The program is through the exchange is quite concentrated. 80% of the enrollment plus is going into Care First products. Kaiser has about 12%, and the remaining carriers make up the difference. Like the federal marketplace, about 88% of enrollees are qualifying for for tax credits, as you might expect, and that significantly reduces premiums, and for folks below 250% of poverty will also reduce copays and deductibles that they might be responsible for. So all in all, it's I think a very positive rollout to date, especially relative to the 2014 launch. Beginning January 1, small group employers are also able to shop for enrollment through the small group exchange in Maryland. Shopping for contracts beginning March 1. 3 TPAs are supporting that initiative, and beginning March 1, employers could purchase what's called the employee choice option through the exchange. That is where an employer selects a metal level, and multiple health carriers would be available based on the employee's preference for coverage. That's something new that was established under the ACA. Historically, we've had employer choice, like most other states, where the employer makes the choice on carrier, and then the employee would choose from those selections. So it's also important to remember that only through the exchange will small group employers below 25 be able to qualify for federal tax credits going forward. So we're anxious to see how this goes forward with the establishment of the small group exchange. Really, the Maryland Health Benefit Exchange has built out both individual and small group requirements under the ACA.
Thanks, Ben. David?
Sorry, guys. Okay. Good afternoon, Commissioners. I do have one addition to the update. Some of this you may already know, but it relates to the Practice Transformation Network funding opportunity announcement that was released by CMS on October 23rd. At the November Commission meeting, I spoke a little bit about the application's design and its intent. In general, it's intended to support 150,000 clinician practices over a 4-year period in sharing, adapting, and further developing their comprehensive quality improvement strategy. Requirements are focused on transforming clinical practice through nationwide collaborative and peer-based learning networks. The estimated number of awards is 35, and the amounts for the award range from between $2 and $50 million per award. Applications are due to CMS by February the 5th, and awards are expected to be made in May. Application development here in Maryland has been underway now for about 6 weeks. The Maryland application is built upon strong partnerships. Chris, the state-designated HIE, will serve as the program manager responsible for all administrative oversight, compliance, and accounting activities. The Maryland Learning Collaborative, which is a partnership between the University of Maryland, Johns Hopkins Community Physicians, and Mhcc, will operate as the learning and diffusion coordinator to promote peer sharing of best practices. Mhcc, the State Medical Society, will be responsible for general clinician outreach activities and engagement of primary and specialty care physicians and mid-level providers. The Mhcc will coordinate metrics and evaluation with the responsibility of developing, collecting, aggregating, and disseminating metric data. The Mhcc will also work with CRISP to develop and implement connectivity of select EHR solutions to CRISP. The draft project narrative is nearing completion. Staff anticipates it will be ready for stakeholder review in the next week to 10 days. Staff plans to engage commissioners in the evaluation of the draft, and we'll appreciate your comment. So more to come on that. Commissioners, this concludes my addition to the update. Thank you.
Thank you, David. Aaron, can you come up and briefly review the MHCC's legislative review process?
Good afternoon, Commissioners. You should have a presentation that looks like this in front of you. It's the same, pretty much the same as last year, the same process, so I'm not going to go through it all, but I'm just going to direct your attention to page 4, which is the position paper development. As you can see, it starts with Ben and I, and then the Center Director and Legal Review, then Executive Director Review, and then it comes to you for Commission review and approval. We will have conference calls as needed. Last year we tried to keep as many of the bills to our scheduled commission meetings as possible, just so we didn't have to have calls, but you know, things come up. It's my prediction that session will start relatively slowly this year, but by the middle of February it should really pick up. Then I want to, you turn to page 8, just to go over the budget. The 10th day of session is January 23rd, which is next Friday. That's when the budget is required to be introduced by the governor. Session started on Wednesday, I should say, and then the new governor will be inaugurated next Wednesday. So it's a pretty quick turnaround that the budget will then have to be introduced. It's introduced by the governor. It's assigned to the budget committees. Our budget hearings are a little early this year. In House Appropriations, it'll be February 11th, and in the Senate Budget and Tax Committee, it'll be February 16th. The next 2 pages are just dates of interest. Page 9 has session dates of interest. And then the last page, we've already been scheduled for some briefings, especially by the HGO committee, that I just want to bring your attention to. On January 22nd, we are going to be in the HGO committee for the whole afternoon. We've been asked to brief them on the PCMH program, the work of the telemedicine task force, the work that we've done on assignment of benefits, and on the MRI study. On February 5th, we've been asked by the HGO committee to present on the freestanding medical facility pilot program. Also on that day, HSCRC will be presenting on the new waiver. On February 10th, we have been invited to talk about our new quality reporting website and initiative. So we will hopefully be doing a demonstration on the website. And then again, on the February 11th and February 16th are our budget hearings. So if you have any questions on the process, just let me know, and you'll be seeing a lot of me in the next couple months. Thank you.
Thank you, Erin. Any other center updates? Okay. The next 2 items are follow-up items of reports that were shared here at last month's meeting that we had feedback on, and that now we're actually approving the report and the transmittal letters. And so just to be efficient with everybody's time, just wanted to follow and instructed staff to follow a couple ground rules, that we remember what was presented last time, and that what we're really trying to do is pick up the conversation from last time. We're not trying to go over everything, but rather just sort of summarize what the issues were and whether there's a couple of things that we need to kind of resolve before actually having an approval. And so Paul and Eileen are going to first present the draft final report on the operation, utilization, and financial performance of freestanding medical facilities. And Dennis Phelps, the Associate Director of Audit and Compliance at the HSCRC, has also joined staff today. I believe, is that right? Okay. Eileen?
Good afternoon, Mr. Chair and Commissioners. Before I get started, I just want to mention that several other staff contributed to this report as well, and I appreciate their help. These include Kathy Rubin, the newest addition to our center, Paul Parker, Sue Ellen Weidman, and Catherine Victorine. I think you understand the context for this, so I'll just speak a little bit about some of the conclusions, some of the material that I covered last time before talking about some of our other conclusions. First, I want to remind everyone that the freestanding medical facilities operate 24 hours a day, 7 days a week. They must comply with EMTALA requirements and Medicare conditions of participation, and they do accept patients arriving via ambulance. And this is in contrast to the urgent care centers that did not operate 24/7. Instead, they typically operate from 8 a.m. to 8 p.m., and they're not subject to the EMTALA requirements. They also may require payment up front from patients without a third-party payer, and they're not equipped to handle patients with major traumatic injuries. So there are 2 pilot freestanding medical facilities in Maryland, Germantown Emergency Center and Queen Anne's Emergency Center, and a third freestanding medical facility which was established initially in 1979, Bowie Health Center. So each of these was established for different reasons. Germantown Emergency Center was established to alleviate overcrowding at Shady Grove Medical Center and to improve access to care, which was seen as a challenge due to heavy traffic volume and the distance to the hospital emergency departments for the population to be served. Queen Anne's Emergency Center was established to improve access to emergency services. Queen Anne's County does not have a hospital, and traffic volumes and closure of the Bay Bridge at times were also seen as significant barriers to accessing services. There was not a concern about overcrowding at the hospital affiliated with it. The third freestanding medical facility in Maryland, Bowie Health Center, was likely developed in lieu of a general acute care hospital, which was authorized in the 1970s. It was established at a time when the urgent care model was relatively new, and these weren't as common. Until recently, it did not operate 24/7 as required of freestanding medical facilities. So the very different objectives for these 3 facilities and the very different market conditions under which they've been established make it a challenge to define the circumstances under which freestanding medical facilities should be allowed to develop. However, staff believes that both the pilot projects have been successful in meeting their objectives and are examples of appropriate circumstances to develop a freestanding medical facility potentially. Germantown Emergency Center, as I mentioned, was established to alleviate overcrowding at the parent hospital, and there was a large reduction in emergency department visits at Shady Grove Medical Center in the year following the establishment of Germantown Emergency Center, and the growth in volume in subsequent years was moderate or lower than the prior year. Queen Anne's Emergency Center was, as I mentioned, established to improve access to services, and representatives from Shore Health System mentioned that the zip code areas for patients using Queen Anne's Emergency Center have trended towards the southern end of Queen Anne's County and northwestern Caroline County, which are areas where no emergency services existed before, and accessing such services would have taken an hour or longer. So now the EMS transport system is able to pick up and drop off patients more quickly. The average transport time to Queen Anne's Emergency Center was 11 minutes in 2014, while the average time to get to the University of Maryland Shore Medical Center at Easton was about 28 minutes, and the time for Anne Arundel Medical Center was about 23 minutes. Based on the example of Bowie, which was developed in lieu of a hospital, we think, and discussions that we've had with other hospitals and communities about the role of freestanding medical facilities, it also may be appropriate to develop these types of facilities as an alternative to a small general hospital, which is relocating to another community or being considered for closure because maintaining or modernizing it may be excessively expensive. So besides considering when it might be appropriate to allow development of the freestanding medical facilities, we also want to consider the cost effectiveness of these types of facilities, which could vary based on the objectives of the freestanding medical facility and the location where it's developed. Because the acuity of patients seen at the freestanding medical facilities in Maryland is much lower compared to the affiliated hospitals, we do think it's important to consider whether an urgent care center or other office-based care could be an alternative for some of these patients. So the table on this slide shows the number and percentage of visits by acuity level that did not result in a hospital admission at a freestanding medical facility or the parent hospital. And level 1 is the lowest level of acuity, and the highest level is 5. So as you can see, the percentage of level 4 or 5 visits, the highest acuity types, are much higher at the hospitals compared to the freestanding medical facilities for fiscal year 2014. Less than 1% of visits at Germantown Emergency Center were level 5 compared to 8% at Shady Grove Medical Center. And about 20% of the visits at Germantown Emergency Center were level 4 as compared to 35% at the parent hospital at Shady Grove Medical Center. For Queen Anne's Emergency Center, the difference is less dramatic in terms of the highest acuity visits, level 5. It was about 3.4% of visits at Queen Anne's Emergency Center compared to 5.2% for the University of Maryland Shore Hospital at Easton. But with the level 4 visits, which were also very high acuity, the hospital did have a considerably higher percentage of patients as compared to Queen Anne's Emergency Center. It was 31% of visits at the hospital versus 21% at the freestanding medical center. And then at Bowie Hospital Center, 9.1% of visits were of the highest acuity, which is a much greater percentage compared to the other freestanding medical facilities, but still dramatically lower than for Prince George's Hospital Center, which was about 36%. On this next slide, I have the number of patients admitted and the percentage for the freestanding medical facilities and the affiliated parent hospitals. So as you can see, the percentage of patients admitted from the freestanding medical facilities is a lot lower as compared to the parent hospitals. For Germantown Emergency Center, between 2012 and 2014, only about 5% of the visits resulted in admission to a hospital, compared to between about 15 and 18% for Shady Grove Medical Center. And it's a similar pattern at the other facilities you see here. For Queen Anne's Emergency Center, it was only about 3% of visits that resulted in admissions, compared to 16 or 17% for the University of Maryland Shore Medical Center at Easton. And so as I've noted in the staff report, none of the freestanding medical facilities, or rarely, have they generated a positive net revenue. And so the one exception is Bowie Health Center in fiscal year 2014. And while that could be interpreted to mean that such facilities are not financially viable, which is an important general criterion for looking at certificate of needs applications, it's important to keep in mind that hospital emergency departments generally are not seen as profitable either. And one of the 3 hospitals affiliated with one of the freestanding medical facilities did provide an estimate of the profit margin for the hospital's emergency department, and it was negative. I also want to mention that very recently, representatives from the University of Maryland Shore Health System told staff that the fiscal year 2013 audited financial statement requires a correction, and it doesn't accurately reflect the revenues and expenses. This was news we got just yesterday. So I checked, and I'm not sure that HSCRC is aware of that, but the largest difference is for expenses. The representatives from Shore Health System said that approximately $1.5 million in expenses was attributed to Queen Anne's Emergency Center when it should have been attributed instead to the parent hospital. It doesn't actually make a difference in terms of generating a profit that year or the conclusions that we reach, but it does make their financial performance look a lot better. So we'll follow up further on that issue, and we may wind up adding a note to the report. So on this slide, which I presented also to you in December, I have the financial performance for Germantown Emergency Center for fiscal years 2007 through fiscal year 2013. And I'm showing you this because we were asked to evaluate the impact of rate regulation on freestanding medical facilities. And Germantown Emergency Center is the only location that's operated both with and without rate regulation from HSCRC. And so, as you can see, the net income was negative in each year, ranging from a loss of less than $200,000 in fiscal year 2010 to a loss of $1.9 million in fiscal year 2013. And it does not appear that Germantown Emergency Center had a much better or worse financial performance before or after it became rate regulated, which was in the middle of its fiscal year 2011. In terms of the impact of rate regulation, I think it may have been expected that it would be helpful in ensuring that these facilities are financially self-sufficient, but it doesn't appear that that's the case. As far as some of the key conclusions that I've mentioned, just to recap, development of a freestanding medical facility may reduce crowding at the affiliated hospital's emergency department. It can increase access to care, as it did for Queen Anne's Emergency Center and the other locations. And it may effectively serve as an alternative to developing a hospital in some cases, or replacing a hospital. Also, the freestanding medical facilities serve a population with less acute medical needs as compared to patients that show up at hospital emergency departments. And the vast majority of patients' visits at freestanding medical facilities occur during hours when a viable alternative for treating minor urgent problems may have been available for some patients. And so, as I mentioned, that leads us to be concerned about whether or not there's an alternative setting, or we need to kind of focus on getting patients into the best, most cost-effective setting. And so this last point is that a hospital seeking to establish a freestanding medical facility must justify whether less expensive models of urgent care delivery cannot meet the needs of the population to be served. As Erin mentioned, we're going to present this report to the House Government Operations Committee in early February, and we expect that their feedback may shape the process going forward in terms of further work. The goal is to develop new regulations for these types of facilities in this upcoming year. That concludes my presentation. If you have any questions, I'd be happy to answer them. There is a lot of detailed information that was included, I think, in Appendix 4, the profiles for freestanding medical facilities, but we didn't want to overwhelm everyone going through a lot of details, and just kind of get right to the point.
Just to answer questions if I can.
Okay.
There was a lot of things happening, revenue, contractual adjustments, charity, income, and as commissioners, we're not. This was not our expertise around financial performance, and really wanted a perspective from the HSCRC around how to interpret these numbers. So, yeah, because I mean it was just pretty interesting around how gross revenue was going down despite higher visits, and then there was just a lot of shifts in the charity bad debts and contractual adjustments. So that could just be changing this overall conclusion.
This is a pretty gray area sometimes. When you get one thing that's not on here is denials, which I assume they're probably falling in contractual allowances when they get denied payment to if these are they shouldn't be going to this facility even. So I would think that you can see that number jump around, contractual allowances. Prior to the time that they were rate regulated, they were treated as physician's practice basically. And so that there was a significant contractual allowance involved. You can see it was $4 million at one time. Charity and bad debt, at least since they've been rate regulated, they follow the same policy as the hospital, as Shady Grove Adventist Hospital. Why the charity is why they fluctuated so much, hard to say. I'm not sure whether Shady Grove has gone to the presumptive charity policy or not. That could be a factor as to why charity might go up a little bit, is that they try to determine, even if they don't have all the information just from sources that they can get information as to whether someone would be eligible for charity if they filled out all the forms.
So at a high level, what's the HSCRC's view on the financial performance of these freestanding medical facilities as you've looked at it?
Well, they're not breaking even, that's for sure. We look at that when we set rates as to whether the rates are set appropriately for the services provided. We believe we're setting the appropriate rates because we're comparing them with each other, plus we're comparing them at, when we can, with the emergency rooms at hospitals, especially hospitals that are close to these facilities. So we think the rates are right, or pretty close to being right. But why they're operating at maybe just that they're not efficient at the levels that they're operating.
Thank you. When you said that the charity and bad debt approach is being taken as the same as the hospitals, could you explain that a little further? For example, there are places, and I realize this may not be how it's done in Maryland, so I apologize for my ignorance here, where charity is considered the difference between, for example, what Medicaid pays versus what the charges are. So could you describe, just briefly, charity, bad debt?
No. Yeah, you have to remember, this is an all-payer state. There isn't any difference between what Medicare pays and what everybody else pays. So there's not that gap you have to fill in. The policy, there are regulations that we have that are a product of legislation that says here's a minimum charity care policy. And each hospital has to have their own charity care policy, has to follow it with us. They have to meet the minimum guidelines. And the minimum is 200% of the poverty level. There's free care. And then there's a scale going up from that.
So just to make sure I understand, when charity care is listed here, it truly is care for which there has been no charge to the patient.
Right.
Okay. Thank you.
Okay. Fran,
so to follow that, the report, I guess my copy is what page is it? It's table 20. There's different versions. Table 20, page 27 on the original single-sided report has an analysis of the 3 centers for 2011, 12, and 13. And in the instance of Queen Anne's is booking 0 for charity care for 2011, 0 for charity care in 2012, and 0 for charity care in 2013. So I don't know how to interpret that. Maybe I'll just leave it there. I don't know how to interpret that. And it raises a bigger question of if these freestanding emergency centers are units, basically remote subsets of the parent hospital, then is it incumbent on the parent hospital in aggregate to book a predetermined amount of charity care, which can then be distributed across its service centers, or how does HSCRC really look at the finances of these 3 units as a subset of the parent organization?
Yeah. I can't explain why they're reporting the way they are as far as charity care is, and in fact, the bad debts look not.
Bad debt looks pretty like there isn't any.
Yeah.
So this doesn't look, to be real, this doesn't really look accurate.
Arlene, does Queen Anne's have an interest in restating any of this data? You know?
I can follow up with them again. I think the charity care is something where they needed to get back to us, and they haven't been able to get back to us in time for this meeting.
Okay.
So we have tried to follow up with these hospitals to verify their thoughts on the information we've presented.
So just to clarify for the commission, it sounds like at least at a minimum at Queen Anne's Emergency Center, there may need to be some changes that correct this information that are in the...
I don't believe this information is correct. I really don't. What's built into rates for all of these centers is a substantial amount of uncompensated care. It's 12% in, I think, all three instances, at least 12%. It's built into rates. So that's what we have looked at their prior experience, when there was prior experience, and what expected experience is, and that's what we determined to be. It's less than it is would be in a hospital emergency room, but more than an inpatient facility, in the inpatient portion. Now, why this is the way it is, I don't know.
So I just want to clarify the facts as they stand, because it's going to change what we can and can't do at this meeting. So are you telling me that there's a couple of this information that's going to ultimately need to be amended, and is it only Queen Anne's or is it others?
I mean, the way we look at this is the information came from audited financial statements. So, I mean, this is what was on the audited financial statements, and in that sense, it's accurate, but it was surprising to us, and I think if they file a correction, I mean, that's something we can note, and it would be important to note that subsequently there was a correction to it.
Yeah, these are, in all three cases, these are consolidated financial statements from a system, and they break out into the components of the system, the relevant information, and it's hard for me to believe that this is accurate, and that may be where the problem is when it was broken out, that not enough was allocated to these facilities, because when we set the rates for these facilities, there was considerable, uncompensated care associated.
Barbara?
To follow up on that, the other thing you might want to look at is if they were eventually admitted into the hospital, did the charity care follow them there? And that's where it was billed, as opposed to in the outpatient when they were in the ancillary facility. That the whole bill followed them over to the hospital.
Yeah, but
that's where it might have been.
Right.
Yeah. Even though it shouldn't have been, that might have been what happened. But I'm sorry, didn't mean to interrupt you.
But what you're seeing here is the gross revenue associated with those that weren't rolled over into the hospital. So the percentage of that is really low. It's not like you're seeing the gross revenue with including those that went to the hospital, were admitted to the hospital. That's not in here, because if they're admitted to the hospital directly from here, then it's not going to. It's going to roll over into the hospital.
Okay, so it's not in here at all.
Into the hospital.
So it still bears inquiry.
Yeah, it does. They're very low numbers.
So just to clarify that point, that if the revenue that is generated through the ED for patients that are transferred to the hospital, admitted to the hospital, that revenue doesn't get reflected in this statement. Is that what you're saying?
If they're admitted, it gets picked up and is rolled into the inpatient bill.
Okay, so I mean, one of the challenges I think with trying to interpret these statements, especially when you're looking at it in the context of is this a going operation, is that some of the revenue that's generated by the satellite facility, and this applies to the ED as well, is accounted for by a different unit of the system. Is that correct?
Right. I had one other question that I had meant to ask before that. I think this is a really good report, though, in many ways, and that it absolutely captures the nuances between these three different facilities, which are quite different. But my question was, in times, say, of healthcare crisis like the flu epidemic, those kind of things, does this kind of facility provide surge capacity for the hospital and for that system? Because I know I've had a couple experiences where the hospitals were on yellow alert, a number of them, their emergency rooms have been filled with flu, and in the meantime, you know, patients are not seen because other patients are being held in a bay waiting to get into a hospital room because they're going to be admitted. And I'm wondering, do these facilities actually not only see patients, which helps the capacity, which you said, but also perhaps hold them until there's a bed at the hospital and in that way help to deal with healthcare crisis?
I would have to follow up with them to know for sure, but it seems like something that potentially they could do, but I would have to follow up to know for sure if that's something they do.
I think ambulances are directed when it's alert to another hospital. I don't think they could go here.
I think they can go here.
Yeah, I mean, they take ambulances when patients need their care. Like, there is a protocol, and they will take patients that need immediate care.
All I was going to say, it kind of relates to what Ben said, was, you know, I look at this as like looking at one department in the hospital doing a review that's not making money, but the hospital itself is doing well. You know what Deming always said, the most important numbers are unknown, unknowable. Who knows how many surgeries came from these centers to the main hospital, how many follow-up visits, how many outpatient care and services in terms of the financial health of the hospital that's affected by this one, which may look like it's losing money. So that's how I look at this. It's just an arm of the hospital supporting the big picture.
Right. It seems like that's the way some of these health systems do look at it. They would say, well, we got this extra revenue from patients that showed up at Germantown Emergency Center, and then they were admitted to the hospital. So they do see it as a positive that offsets what looks like high costs.
Well, so to be precise, I mean, I think your conclusion was very, very precise. You said it doesn't, I think the quote was guarantee that it will not guarantee that they will be financially self-sufficient. So, and I like that statement. I guess the question I just have is if there's some concern that Dennis is bringing about whether this information is completely reliable, are there any scenarios in which that changes the material conclusion of the report? So that's, I mean, that's.
I don't think it would. I mean, I think most people might look at it and say, maybe we shouldn't do this at all because it's a negative financial performance. And we're not saying that. We're saying, in spite of it looking like they don't perform that well financially, this is an okay model moving forward. So I think because that's our conclusion, I wouldn't be concerned that if they look a little better, if they actually do perform a little bit better, that we would change our mind in terms of that conclusion.
So what would you both propose is the process to deal with this question about accuracy of the data? I get your point that it's from the audited statements and they are what they are, but now you're looking at us and saying, hey, I don't believe this. So do we either incorporate that into the report that there's a question about this, or just communicate that to the hospitals, or what?
No, we'll get an answer for you. I will personally come back and give you the answer. We'll find out.
Okay, so you're saying that post this meeting, you're gonna get to the truth.
Absolutely.
And that if we get any kind of amendments in that would be incorporated into the report.
Yes.
I like that. Yeah. Okay.
So just go ahead.
Yeah, Michael.
So, yeah, go ahead, Michael. I have sort of a conclusion appointment.
Okay, thanks. Slightly different direction. Great report. I agree with all the statements. But on page 7, I was looking at the statistics in terms of the long waits that they put in here. And I was like, whoa. But at time of arrival to hospital admission,
right.
Not a very patient-friendly type of number because only a certain percentage of patients actually get admitted. It's really the wait time to disposition that might be more user-friendly. I know it's not our statistic. We're getting it from ACEP. But is there any other breakdown that we could be using to help us understand what actually is happening from the perspective of a patient goes to the emergency department and doesn't get admitted?
I can certainly look into that. I do understand your point. I mean, seeing those numbers, it is a little bit scary. And I feel like, well, what I want to know is how quickly do I get evaluated? Really,
exactly.
Am I going to wait around a lot before I even feel like I got evaluated more than just like a screening?
Right. In time to disposition, discharged, admitted, transferred, that kind of stuff would probably be more relevant for our quality reports or something we do.
Okay.
Since Tress is not available to respond, the
Right over there.
well, I can sentences. I know this because these are sentences I added, which are that we wanted to draw information from our hospital quality report into this report, and these are actually these are measures that are reported in the quality report. I agree with you. It would be better to have a broader metric that covered all patients, but what's reported in the hospital guide is from arrival to
right. I agree. I understand we're using information that's available from our report, but that may not be a reflection of the function of the emergency department itself. It's a function of the hospital transfer system, beds availability, all the kind of what's happening in the emergency department would be a nice group of stats that we can pull in.
Other comments or questions? Fran?
Thank you for this report. And this is a precursor to some regulatory work, perhaps around CON development for this class of provider, right?
Right.
And so I want to just express a little unease about something else, not the financials. The financials are concerning because once we get to them, it's clear that these 3 centers are a drain on the parent organization and therefore on the larger system. So it's a financial cost. Now maybe the improved access is a worthwhile trade-off, but nevertheless, there's this financial footnote. But then there's the other concern that having these facilities available may siphon off primary care, which is not as effectively provided in these centers, particularly because of the disproportionate high volume of low acuity patients that present at these centers as opposed to a primary care provider in a much more holistic patient-centered medical home approach. So I have another concern about the demand impact, indirect impact that these centers may have. So just something to flag in the future as we think some more about regulating these kind of centers.
Okay. Well, thank you for those comments. We do want to keep that in mind. I guess I just want to note that from the perspective of the parent hospitals, they don't necessarily see it as a drain on the system. Like with Germantown Emergency Center, like Shady Grove Medical Center does see it as something that is a net positive because of the hospital admissions and revenue from those visits. And then also, Bowie Health Center, recently their financial performance looks better, and they have expressed that they think that it will continue to look better going forward. They had been underestimating or underclassifying the acuity of patients. So I just wanted to be a little bit clearer on that point.
That data might need to be tweaked as well. So.
Well, it's important to keep in mind. I mean,
thank you.
So I think Mr. Phelps could maybe help with this, but we've talked a lot about rate regulation and the various reimbursement structures that would be available. Sort of as a rule of thumb, and I realize you probably can't do this real accurately, but so when you go from a, let's say a physician fee-based reimbursement to Medicare OPPS to HSCRC regulation rates, how would that, say, on a dollar of cost? So we might say Medicare fee schedule would be maybe 25–30% of cost. The hospital would tell you OPPS would be somewhat higher. Where would HSCRC rates sort of fall? I mean, they would be theoretically close to 100% of cost. Is that the way to look at that?
Yeah.
I mean, I want everyone to sort of walk away with, sort of how and why this matters, and why getting rates matters to these facilities.
Hospital outpatient ambulatory rates and ancillary rates in the state are very high. They're higher than they are in the rest of the country, probably on average. So it's not the cheapest place to go, even if it's not a full-fledged emergency center. The costs will be higher. In fact, we're going to take a look at some of our policies in regard to urgent centers in relationship to hospitals, because we don't regulate urgent care centers, but we don't allow hospitals to run them right next door to their emergency rooms either for other reasons, patient direction, that kind of thing, and we're taking another look at that. See, because we want to keep these people out of the hospital if we can, including these freestanding, because it's cheaper to go to an urgent center if that's where you should be.
Terrific. Can I get a motion to approve this report with any future corrected information on the financials that happened from Mr. Phelps' report? Second? Any other discussion or comments? All in favor? Aye. Any opposed? The report is approved.
Thank you.
Very good. So we are now to the assignment of benefits baseline final report that Linda's going to present. If you recall, this was the report that was requested in the 2010 legislation that established rules for reimbursing non-participating physicians who treat patients insured under PPO contracts. And I think last time we did not have our payer colleagues here, so this will be a more informed discussion today.
Right, page down, right.
Okay. Linda.
Yes, so I have two slides because I decided that you guys would absolutely, I don't know why I can't make this go down. Oh, there we go. No? Okay, so where's my, nope.
Which one are you?
It's the AOB.
All right.
Yeah. There we go. Okay, great. So I just, last month, Claudia Schur from Social and Scientific Systems was here and went over all the results in detail, and I'm just going to give you I guess it would be Mount Capitan today, the view of the El Capitan, thank you. View of the report. The first three bullets come from the analysis that was based on our medical care database, which was that overall the legislation seemed to achieve its purpose to ease the financial burden on patients who use out-of-network providers by reducing the reliance on balanced billing. We also saw increased predictability in payments for the non-participating physicians who were affected by the law, which was evidenced by the vast majority of them accepting assignment of benefits from their patients, which meant they gave up the opportunity to balance bill them. And then finally, overall, from the carrier perspective, across all the carriers, the out-of-network services and reimbursements declined as a share of the total services and reimbursements for these hospital-based services between 2010 and 2013. And then the last two bullets come from conversations that we had with the carriers and also an assessment of the Board of Physicians license renewal survey data in which they ask physicians about whether or not they participate in private insurance networks. So from both of those sources, we saw no evidence of a systematic deterioration in the payer networks. But we did note that 2 of the 5 carriers reported paying bill charges in 2013, which is higher than required by the law. So these are the big takeaways from the report. And I hope that we're principally here today to discuss the letter that Ben drafted, which was the Mhcc recommendations on the assignment of benefits law. And the letter includes basically 2 main points, which is the recommendation from the Commission would be to remove the abrogation date, but make no additional changes to the law. In part because changing the payment formula could resurrect old tensions between the carriers, and the physicians. However, the Commission feels strongly that those carriers who are paying billed charges should have as an opportunity to reduce their reimbursement to a lower rate that is consistent with the law, and we're willing to use the information from the medical care database to help facilitate their doing the reimbursements in compliance with the law. And that means we would produce carrier-specific fee schedules derived from our medical care database in 2009, and then provide the MEI, the Medical Economic Index values for each year after 2009 that the carrier could use as inflators. So those are the big points, and if you have any questions you want to ask me or just move to a discussion of the letter.
Any questions or comments about the recommendations or the report?
Linda, I have a question about, because you mentioned that 2 carriers seem concerned. I think the report was insightful. The 2 carriers, none of them is Blue Cross, okay? Just to make sure you know that I don't have a conflict here. But I was just curious, in terms of the 2 recommendations that's in the transmittal letter, have you reached out to the carriers and, you know, some of the other even, have you reached out to the industry to make sure they're okay with the recommendations or not?
With Aaron, we've had conversations with Mhcc, and as part of the conversations that we had with carriers, we do know that there are 2 carriers that do have serious issues with the law. Will our suggested remedy be sufficient to make them happy? That's unclear.
So are we saying that we haven't had carrier discussions?
We have had some payer discussions with one of the payers. We are planning to have discussions with the other payer tomorrow. It just wasn't possible to shoehorn that in given everything that's done. And our very preliminary analysis does suggest that it makes a difference if you follow the law or are paying more generously than is required in the law. So there may be operational reasons why simply paying billed charges today is implemented as opposed to going back and paying what was reimbursed in 2009 and inflating it forward. The opportunity to use the Mhcc data may alleviate whatever administrative headaches may have caused paying of billed charges. But no one has said to me that the reason I'm paying what I'm paying is because I can't figure out how to do what the law says. We don't know if it was an oversight. We don't know if it was simply administrative simplification, or probably less likely, but a possibility is that we want to reduce payer-provider conflict. We're just going to give them what they think they charge. And I think that Linda made this point last month, but maybe didn't emphasize it, is that we generally think that network participation is increasing. That's most obviously evidenced by the fact that I believe it was 1 in 10 or 1 in 5 patients had an out-of-network service in 2010, but that number had decreased to 1 in 10 in 2013. Is that correct, Linda?
That is correct. And but we wouldn't necessarily say that, how that applied to the law, because when we looked at patients, we took the patient's perspective, which is they look at all their spending, all of their health care utilization. So across all their health care utilization, there was a big drop in the number of patients or the proportion of patients who had out-of-network services. So on balance, it looks as though either the networks are growing or patients are getting really good at staying in network.
Or shopping.
Yeah.
And one other factor in terms of hospital services that you have to keep in mind, independent of this law, is that there's, like elsewhere, there's a growing trend toward hospital acquisition of physician practices. And a system is likely to be much less focused on not participating in a network with their whole range of services than an individual physician practice would be that's looking at it narrowly. So, for example, at let's say Shady Grove, who is here we talked about today, as they acquire hospital-based practitioners, they probably, as a rule of thumb, are always moving them in to par contracts, although perhaps historically the emergency department physicians that formerly served that hospital may have, on a situational basis, contracted or not contracted.
Any other questions or comments? John?
Do we know, since the way the law was written, that there are two different ways to pay, and it's based on the lesser of, not the greater of? And you can get into more detail that. Do we know how, on a level playing field, that affects carrier by carrier? Meaning, is there a carrier or carriers that are at an advantage because of the way that they previously paid and the way the law's written, or is there a level playing field for everybody? Has that type of analysis been done?
Well, I think it's clear, and I think it does state in the letter that there really are two. The law establishes two tiers of payment, and the first tier of payment was those carriers who were paying bill charges, higher amounts by the law, were sort of held to maintain, to be locked in at that level, and then grow it through the inflation rate and the medical economic index, so that it couldn't fall below that. And then in the case of the other carriers, the three other carriers, and there were three in the report, it says there are three carriers who are paying by option 2, which is the average reimbursement within the current year inflated to 140, for in-network inflated to 140%. And so I would say that the issues with the law fall very clearly along those lines of the carriers who got tied into the higher payment option, and I think that is mentioned in the letter, that those people, that it created two tiers on purpose so that there wouldn't be any cutbacks in payments. However, I do think that by paying billed charges, that's a lot of icing on the cake. So, if those carriers, yes, at least in the short run, they're being penalized. I think we did a little mathematical calculation and said that if you care over time, the difference will shrink between those two payment options in the law. We didn't figure out exactly how long it would take, but we do think those two would decrease. But I think the fastest way for the carriers who are paying bill charges to decrease the difference is for them to not be paying bill charges in the current year, but to be paying the bill charge from 2009 inflated forward. Did I answer your question?
Perhaps. But you have acknowledged there is a disparity between carriers.
I do believe
and
that.
We don't know how long that would take, or in theory, you're talking theory that
that's right.
Over years it would come together, but we don't even really know that.
No, we don't. But I just wanted to be, that's my impression from reading the letter, and I just wanted to make sure the other commissioners also get that impression from, that we understand that there's a difference in the two payment methodologies. And was that clearly communicated in the letter? Okay.
Other questions or concerns? If not, I'll hear a motion to approve the submission of the report to the Governor and the Maryland General Assembly. So moved. Second? Okay. Abstain? One abstention. 2. All in favor?
Aye.
Aye. Any opposed? 2 abstentions. All right, motion carries.
Great, thank you.
We now are on agenda item number 5, which is Provider Carrier Workgroup Membership and Process. So House Bill 770, Mhcc Healthcare Provider Carrier Workgroup, was passed in the 2014 legislative session, which requires the Commission to invite professional organizations, carriers, and consumers to serve on the work group, solicit issues for consideration, and report to the General Assembly annually beginning January of next year. Aaron Dorian is going to present the proposed membership and meeting schedule for our approval. Aaron.
Thank you, Mr. Chairman. I told you all you'd be seeing a lot of me the next couple months, so I'm starting early. The first slide just goes over what the Chairman went over. The legislation was introduced by Chairman Hammond in response to our success working with carriers and providers on initiatives and issues like PCMH, prior authorization, and step therapy. The General Assembly felt our role as a convener of interested parties should be codified in law. This group can only consider issues where there is no other state agency which has jurisdiction. That's an important distinction, so we won't be getting everything. We will only be getting things where there is no other agency where the issue would fall. So I'm not going to go through the list of participants word for word, name for name, but I just want you to think of this as a fluid group, and these participants are the foundation of the group. It's not an inclusive list. If things come up where there need to be other participants, we will bring them in. These meetings will be open. You can see that on the payer participants, we have all the major payers listed. We do have a name from Cigna. It's Matthew Sahada. He's the Provider Services Specialist. So provider and consumer participants are on the next page. We have physicians from various practice sites, various specialties. We have asked a person from the Office of the Attorney General to sort of generally represent consumer interests, and we will bring other consumer representatives in as we need them. We also have 2 more to add to the list. We have 2 people that the MHA has added. I can't say their names yet because they haven't been told, but we have a representative from MHA and a representative from a hospital. So the issue solicitation and structure, again, this is an informal group. So issues are driven by commissioners, policymakers, and the participants themselves. The work group, we have thought this through, and we think that this work group should meet quarterly. We have talked to both provider groups and payer groups, and they asked that the agenda be distributed prior to the meeting so there's no, surprises of what issues may pop up on the agenda. But this should be sort of a fluid thing where the issues that are discussed will change from quarterly to quarterly, unless there's something big like step therapy, in which case this group would be the group where that would land. Any questions?
Just actually 2. One, when this bill passed, was there a fiscal note associated with it of any amount of money?
I think we estimated, what, about $50,000 a year?
And secondly, in terms of process, does this mean if there are no other issues that the General Assembly can't resolve during the session that they'll send a note and say, please refer this to the provider? That was Pete Hammond's idea.
Yeah, and I think that so what Delegate Hammond felt was that this was happening. Every year there were issues coming to the General Assembly that that he was then just referring to us. That will continue to happen, but what he's hoping is that before the issues get to the General Assembly, this group can take them up preemptively. And now that's not going to happen all the time, but that's the idea about how this should work.
Okay. Thank you.
Please flip back to the slide with the members. Right there. Just on the clinical side, I see the American College of Emergency Physicians. On the other clinicians, I see physicians, I don't know if there's nurse practitioner, physician assistant, and what specialties are represented outside of the MedCon. Presumably they're not primary care physicians.
So
Could help elaborate.
I should have had a list about exactly what types of physicians these are. I believe one is an orthopedist. I'll have to look back on who the others are. Primary care, we have Paul Andrews from Patient First. We would, of course, bring in any nurse practitioner or any primary care doctor that wants to sit on this group. This is just the base group, and then it can build from there.
Fair enough.
Nobody's going to be excluded.
Fair enough. I just want to make sure that there was adequate representation of the other clinical members, because you have one primary care, and I didn't know if those are all subspecialists or specialists, and then emergency physicians. So looking at the balance of the issues.
Yes, sure.
And also, I wasn't clear if there are any nurses on it.
So the one consumer representative listed here, I don't know who that is. I mean, it would be interesting if you have any other information about the individual, but also has there been consideration of groups such as the Maryland Consumer Rights Coalition, the League of Women Voters, AARP, other groups that, unions that often have folks who are available to be consumer representatives on groups like this? I personally would love to see more than just one name. Not that, I mean, that person's probably awesome, but in addition to that person, is what I'm saying. So that's one request, that there would be more consumers than just one individual. And then the other question is around what is the process for when, or who decides when the issue requires more consumers involved? And two, what's the process for bringing them in a timely way so that they are just as much up to speed on the issues as the people who are on the standing committee?
So I think I'll speak to your first question, then I'll have Ben speak to your second question. So Adrienne Ellis, again, she's from the Mental Health Association. We have two other consumer names that I'm getting, but I don't have them yet, which is why they're not on this list, but I'll send them to you as soon. We're sort of in talks with.
So are those, you mentioned one from MHA and one from a hospital, but they are
No, there's two additional people that I forgot to mention.
Thank you.
See, we're pulling this group together. We're trying to pull from a lot of different different areas. So it's been slow getting all of the names. But I am talking with somebody involved in consumer issues, and she's trying to get us a couple more names for consumers. And then for your second question, Ben.
So, I mean, it's a little hard to explain this group. This is the anchoring group that we want to have to start the process. That my expectation is that as issues were identified, we would have a broad mailing in terms of who would participate, who in inviting others to participate that would fill this out appropriately. We can't exhaustively define a work group at this point. We'd probably end up with 20 or 30 individuals, and I think that it's not exclusive to the folks appointed, but we, in order to get this moving forward, according to the our understanding, given that it's formally convened by the legislature, we have to bring these group names forward to you to get it started, and that it would not be exclusive to the about 15 people that have been flagged so far, that others would be at the table and invited depending on what issues are. And it's not that we plan to exclude anyone, but it is sometimes darn hard to get consumers on issues that are not related, that they don't see directly tied to a consumer issue on certainly things like step therapy. The physicians that argued for a better policy here in Maryland brought loads of consumers to the table on that particular issue. So I think we'll do okay. I think Adrienne Ellis will be a good group. She's also very active in the Women's Coalition in Maryland, as well as the Mental Health Association. And I have enormous respect for Kim Camarada, whose her position is not defined there, but she's general counsel for the consumer group within the Office of the Attorney General. And I not only think she's a very effective voice, but she's also very capable in mobilizing other consumer groups if she thinks the issue warrants input. So we definitely are not excluding participation to the names, but we view this as a starter cell.
And given that it's a starter cell, I think maybe the minutes should reflect sort of a synthesis of the Commission that if we're looking at the provider-consumer, we want to bolster consumer representation where possible. On primary care, make sure that we at least have a nurse practitioner, a non-physician representing primary care as well, to just sort of balance that out, kind of connecting that to prior Commission meetings and comments about representation. So, but no specific person, obviously. Any other comments? Otherwise, can I get a motion to approve the membership of the provider carrier work group? Second? Second? Okay. All in favor? Aye. Any opposed? Motion carries.
Thank you very much.
Thank you. We're on to agenda item number 6, which is an assessment of state hospital and local health department's EHR system. And Angela and Nikki are going to present a summary detailing the EHR adoption by both Maryland local health departments and state hospitals, and address the opportunities to advance EHR adoption.
Good afternoon, Commissioners. We're very pleased to present to you today a brief on an EHR environmental scan of state hospitals and local health departments. As you know, staff typically annually assesses acute care hospitals, ambulatory physician, as well as long-term care, EHR adoption and use, including other health information technology. And this is the first time we've engaged these groups, and we're looking forward to working with our partners at the HMH as local health departments and state hospitals begin to explore opportunities to advance EHR adoption. Nikki Mhcc will present the findings from our environmental scan and also overview our recommendations.
Good afternoon, Mr. Chair and Commissioners. While staff has had some involvement with local health departments and state hospitals in the past involving EHR diffusion, not until recently, Delegate Dr. Dan Moorheim expressed interest in exploring opportunities to further advance EHR adoption in local health departments and state hospitals. He inquired about their adoption of an EHR and their plans to implement one, and he was particularly interested in exploring whether VISTA, the Veterans Health Information Systems and Technology Architecture, might be an ideal solution for local health departments and state hospitals. Staff subsequently commenced an environmental scan to identify the current EHR landscape in local health departments and state hospitals, and this presentation will provide an overview of the summary we're preparing. So here are two types of EHRs, open source and web-based. As previously mentioned, VISTA is an example of open source software, and with open source, the coding that is the backbone of the system is not proprietary. Instead, the program is introduced by a company or organization and made available to users to download for free. Users have access to the code to modify it to meet their specific needs, and then any changes they make must be shared with other users. On the other hand, web-based EHRs such as Epic and eClinicalWorks are different than open source in that the source code cannot be modified by users independently. Instead, it's maintained and developed by programmers within a single proprietary company, and typically they charge a licensing fee for the right to use the software. Open source is free to acquire yet costly to implement and maintain, which is why it's typically not ideal for smaller resource-strapped clinical settings to acquire this type of technology. Web-based EHRs cost more upfront, but have ongoing on-demand support, technical support. As part of our environmental scan, we surveyed all 24 local health departments and 11 state hospitals. The purpose was to determine
their adoption and use of an EHR, including the vendor names and the length of time they've been using that EHR. We assessed their interest in using open source technology and their plans to implement an EHR. And we also evaluated challenges around EHR adoption and potential opportunities to help advance their EHR initiatives. Here are some key findings from the environmental scan. As you can see on the graph, around 15 local health departments, or 63%, have adopted an EHR, compared to only 4 state hospitals, or 36%. All of the EHRs in use by local health departments are web-based systems, and the names of those vendors are listed here on the right. And on average, the average length of time local health departments and state hospitals have been using an EHR ranges from 1 to 4 years. Several local health departments utilize more than one EHR in an effort to support multiple clinical programs for behavioral health or dental. In terms of regarding local health departments' plans to adopt an EHR, currently 5 of the 9 that have not yet implemented one are planning to implement one in 2015, and the remaining 4 are in the process of assessing EHR vendors. Local health departments and state hospitals identified the top 3 challenges with acquiring an EHR, and the first one being the cost to acquire, update, and maintain the software, as well as the ability to meet that EHR, to meet that facility's needs. As I mentioned previously, they have to support multiple programs, and several local health departments have actually switched EHR vendors in order to find a product that better fits their needs. Also, the limited availability of technical resources is challenging for the state hospitals and local health departments as well. State hospitals are currently awaiting direction from the Department of Health and Mental Hygiene, and that is in part due to DHMH's plans to conduct a more in-depth EHR needs assessment. The goal of the assessment will be to identify a single solution, EHR solution that meets both state hospitals' needs. State hospitals will be required to implement the EHR that DHMH chooses, and local health departments will not, because they have already invested into existing EHR platforms. Due to this, staff focused its recommendations on local health departments more narrowly. Among other things, the assessment will evaluate their needs, and engage both local health departments and state hospitals to evaluate solutions that might work for them, particularly needs around supporting various service programs, state reporting and analytics capabilities, as well as being able to integrate them with their billing systems. The recommendations were developed in collaboration with local health departments, and they aim to help support them in their adoption and use of EHRs. Local health departments stated they would like to know what others are doing and would like to share best practices and lessons learned to help inform their adoption and use of EHRs. So one recommendation is to establish an Ehr Directory, which would list the current EHRs in use and a primary and secondary point of contact. This would help enable local health departments to reach out to one another if they have a question, and it could be enhanced over time to add potentially a usability rating and highlight key weaknesses or key strengths of that EHR being used in that facility. Various user work groups could also be established to help support EHR education initiatives. The work groups could further facilitate learning and collaboration. Specific work groups could be developed by EHR products or their information needs, as well as they could explore other health information technology opportunities. In terms of next steps, staff plans to submit the summary of our findings and our next steps to Delegate Dr. Dan Morheim and other key stakeholders. And we will continue to provide ongoing support to local health departments in implementing the recommendations, as well as provide support to DHMH in identifying an EHR solution for state hospitals. That concludes the presentation. I'll be happy to answer any questions.
Any questions?
Thank you. I have a quick question about what you might have heard from health departments regarding
consistency of state reporting. So I would imagine, as a person who used to work in a local health department, that you have so many different reporting functions that are required of you that they are flipping around because they're trying to find the exact right one that might give them everything that they need to give what they have to give to the state and to other funders. So is that a part of all this as you consider reporting on this, that there is that sort of discussion that goes with this?
They definitely identified that as a challenge and a need in their EHR system, and that was part of our recommendation, saying potential work groups could be established around that. The DHMH assessment specifically will plan to, as part of their needs assessment, look more into that and make sure that for both state hospitals and local health departments that a solution can meet that requirement. But it's definitely noted as one of the challenges they're facing.
Other questions?
Thank you. Nice report. Two quick questions. I am not familiar with some of the EHRs on. I just went through the list real quick and got through the first 3 or 4. And I know at least one of them is not a certified EHR technology. So I wonder if part of the recommendations would be to move in that direction, because it speaks to my second question about interoperability, connection to CRISP, and interaction with clinicians in the community with the local health department. So just wonder if those are issues on the table.
They're definitely interested in the local health departments participating in the EHR incentive programs. TAC, which is one of the most commonly used EHRs in local health departments, is working on its certification for the 2014 certification. There's some challenges around participating due to not meeting the minimum patient threshold and the doctors not being permanent there and not being able to route their payment around there. But I think there's about 3 local health departments that have received a payment for AIU so far.
Brett? Another point about did any of these health departments talk to you about their school health programs? Because, in one county where I'm actually engaged, there's a very active school health program operated by the county health department with about 300 clinicians without a secure way of communicating back to the pediatrician and the PCT. So they are working with the school system on some open source solution, which I'm not very confident about. If that's just me, so it doesn't matter about me. But really, this whole school health is it's really a site for primary care. It's so important, the level of medications and procedures that are going on in school health rooms, both those run by the health departments and those by school systems, that they get onto some compatible, certified EHR, and I don't think that's happening. So, did that come up in your?
We did not become informed about any open source assessment. We did learn that Howard County, in particularly, spent a little over a year to try and find a solution because it was interested in telehealth, and it has a program that they're rolling out to for school-based health. But that was a web-based solution, so that'll be interesting to maybe inquire further if they are exploring an open source solution possibly.
Yeah, I think it's great what you're doing because these are not experts in this field. It's very much needed, and it's tough for them to find honest brokers of information to turn to. So that's who you are.
And this is a great point. One of the notion of school health records came up quite a bit in the telehealth task force because if you think about it, there isn't a nurse or a nurse practitioner assigned to each one of the schools in the state. They usually have a small number that are floaters. So one of the use cases that was proposed was looking at telehealth technology that would enable the clinician, wherever he or she may go, to be able to communicate back to primary care. The cost of EHRs and the practicality of implementing them in schools far exceeds what could easily be managed and probably not a good use of dollars or resources. Better off to equip the providers in the field so as they travel around, they're able to put information in the HIE, obtain information from the HIE, and then talk to the primary care providers or specialists. So that's been more of the bend on technology in schools.
Thank you.
Other questions or comments? Thank you very much.
Thank you.
Ben, do you have an overview of upcoming initiatives?
So I already had alerted the commissioners that we will be holding work group meetings for several of our priority areas in conjunction with the February meeting. We also expect that we'll have some updates on forecasts for both cardiac services, cardiac surgery, and for our home health agency work group. This is, I'm letting you know this because I think our forecasts, which are typically some of the sort of background information that drives health planning in the state, ought to be more publicly presented and reviewed. These are our goal over the next year is to be more precise in our forecast and allow them to be subject to more scrutiny, and presenting them to the commission formally will be something we'll do in those areas in February. We'll also, we've been working with Aetna on their PCMH application, and we believe it will be complete for the February meeting. They asked us to defer it this month. We'll bring that forward. We expect to have several CONs coming forward, as well as, of course, we'll have I would think, a legislative calendar to consider, as well as we'll know more fully the directions that the new administration will want to take in areas that we have some responsibility. So we plan to begin our meeting earlier before lunch and then continue through the normal recess time, but shooting for a pre-lunch start. We also, as I alerted you earlier, will have some review sessions for our PTM proposal, as well as some of our CON planning over the next month. So thank you very much, and look forward to talking to you in the next several weeks.
Thanks, Ben. If there's no other business, I'll entertain a motion to adjourn. Second? Meeting adjourned.